Hello and welcome to today's webinar for mental health professionals, Racial Trauma, PTSD, and Health Equity, Understanding Racism as a Public Health Pandemic, featuring Dr. Sierra Carter. I would like to introduce Dr. Carter. Dr. Carter is an assistant professor in clinical and community psychology at Georgia State University. Her research focuses on racial health disparities and investigating how psychosocial and contextual stressors can affect both mental and physical health outcomes for underrepresented, unrepresented, and marginalized populations across the life course. She has a long-standing interest in the ways that health disparities in Black American populations arise and are maintained by psychological and physiological contextual processes. A common theme throughout much of her work has been examining how racial discrimination as an acute and chronic stressor affects development and exacerbation of chronic illnesses and stress-related disorders across the life course. Her research aims to aid in improved identification of mechanisms that can be targeted in prevention and treatment efforts to reduce racial health disparities. There will now be a brief moment of silence while I pass the presenter role to Dr. Carter.
Thank you for that introduction. I'll go ahead and get started with this talk today. And I want to preface this by saying this is a talk that I particularly wanted to focus on in this point in time. And I think it's particularly relevant to what's going on today, but also relevant to things that have been going on long-standing for a very long time. So the talk that I'm going to get today is on racial trauma, PTSD, and health equity, and understanding racism as a public health pandemic. And before we get fully into this discussion, I want to give a brief overview of what I plan to talk about. I want to start off by just giving a brief background with some definitions and terms that I'll be using throughout the talk. And then I'm going to move to talking about racism as a chronic stressor in Black lives, particularly focusing on conceptualizations of racism, racial trauma, and health. And then I'm going to talk about systemic components of racism, including the concept of historical racial trauma and its intergenerational effects over time, which I think are pertinent to some of the things that we are seeing more readily on our TV screens today. And then I'll talk about racial trauma and PTSD conceptualizations and what scholars have talked through and conceptualizing how these components can be potentially interconnected. And then my last couple of slides are going to talk about multi-level and multi-systemic interventions as psychologist. I'm a clinical psychologist by training, and how that is related to helping to treat people who come in with racism-related experiences. And then I'll end with some take-home points. So after my talk, some of the things I've been thinking about as takeaways and learning objectives for some of the things that I'll be discussing today is an increased awareness and historical consciousness of racism-related experiences and an understanding of how multi-systemic racism can be, including interpersonal, systemic, and vicarious racism for Black Americans. And then understanding the unique challenges and clinical issues present in experiences of race-based stress and trauma among Black Americans, as well as identifying for either your practice or for healthcare systems broadly, potential avenues that can promote health equity and address the influence of racial discriminations on systems of engagement. And I'll make a case for how these systems of engagement can include multiple systems that we might not think about are important for our mental health services, including the justice system, hospitals, and other forms of healthcare. And so as I get started, I think it's important to think about racism within our current context, and again, about how longstanding this is. I think this picture reflects on how longstanding these issues are and how relevant they are today. And the reason why I talked about my title of this talk is around a pandemic. It's because I think, today it is a point of discussion, but it has been a pandemic, I think, for a very long time. And so I wanted to give a visible image of names of people who have died from police brutality and race-based police brutality. And just to give an idea of just how long and tumultuous it has been for African Americans to experience these types of things and witness these types of experiences over their life course. I remember when I was in graduate school and Trayvon Martin was killed, and it's been about 8 years since Trayvon Martin has died. And just to think about what it means to be a Black American in the US and to have lived through experiencing and seeing and witnessing these types of experiences in your own neighborhood, on your TV screen, as well as in many of your social media outlets that you see today. And I think that is why it's so important to consider as mental health professionals the multi-systemic impact and the multi-level impact of racial discrimination and how that could be something that presents to us when we do mental health treatment. So let's start with some definitions. First, I'll give a definition of racial discrimination. This is just one definition. The unjust or prejudicial treatment of different categories of people on the grounds of race. One thing that we have been finding in our research on racial discrimination is up to at least 90% of Black adults and youth as young as the age of 8 are reported experiencing at least one incident of racial discrimination in the last year. In our history of studying racial discrimination, we thought potentially that youth were not necessarily as affected by racial discrimination as adults are, but we're learning that children are impacted by these racial discrimination experiences, and it has an effect on their health and well-being. Another concept that I'll be talking about throughout this talk is the concept of structural racism, which is the societal systems, social forces, institutions, and ideologies that perpetuate racial inequities, particularly here in the US. I want to also note that discrimination and types of discrimination can differ. So we know that in our racial discrimination, that experiences of racial discrimination can be in vivo, in the moment, as well as vicarious. So that vicarious meaning that is something that we can witness on TV screens, and that can also affect our mental health. We also know that there are experiences of racial discrimination considered traumatic. So those are conceptualizations of racial trauma or race-based trauma. We also know that we have different forms of racial discrimination, some that are considered more microaggression in nature, and some that are considered hate crimes and more objective in nature. And then we also know that racial discrimination has an effect interpersonally and institutionally, and that there are a wide range interpersonal as well as institutional and systematic injustices that are happening that are rooted in racial discrimination practices. And so when I started doing my work on racial discrimination, the main core of what I do is around why Black people die younger than other groups, racial and ethnic groups. And I think in the core of that, I think the visibility of people who have died, people we may not have TV screen, is really important to reflect on, because in my work, one of the things we know is that there are people who are experiencing some of these experiencing racial discrimination, and it's not something that we get to witness or see or something that is on the TV screen readily. It is a part of a daily life experience. And I think it's important to conceptualize, and what I mean by historical consciousness is the within our US system, the legacy, and what do we do when that history is currently engaging in oppressive systems and oppressive practices to Black individuals. And so I want to talk a little bit about racial discrimination as a chronic stimuli, stressful stimuli, similar to how we and our who are PTSD researchers and clinicians think about trauma as a chronic stressful stimuli. We know from research that racial discrimination and trauma impact the whole body system, and that racial discrimination is an important facet of the set of social stressors that exert acute and chronic effects on health outcomes, particularly for Black Americans. And we know that racial discrimination is associated with a variety of mental and physical health difficulties that increase or exacerbate risk for other types of chronic illnesses. And so chronic stress from racial discrimination can evoke physiological changes within our body systems, leading to premature illness and even sometimes death. In talks that I have done in the past, I was contemplating showing this slide for today, but I think it's an important concept to really understand racism and how it has a public health impact, is thinking about models that we typically use when we think about stress response. McEwen's model from 1998 is one of those models. And he talks about how different stressors can affect processes that lead to a concept called allostatic load. So this physiological responding to a stressor. And what you'll notice at the top of the screen is the different types of stressors that McEwen identifies that lead to this process. And he identifies environmental stressors, major life events, trauma, and abuse. And he also notes that an individual's perception of these experiences can have an impact on your mental as well as physical health. So that perceived stress is a cognitive process of thinking about what these stressors mean to me, as well as we're also seeing chemical response. So how much our body is not able to stay in what we would call a balanced state or homeostasis. And he identifies these stressors as something that is impactful to influencing some of the health disparities that we see. More recently, Mays and colleagues have said there's another type of stressor that we might want to consider in this model, and that includes racial discrimination. And I think it's important to note this because in thinking through groups and populations that might disproportionately experience all of these types of stressors, including environmental stressors, major life events, trauma and abuse, as well as racial discrimination, there are particular populations that are more likely to have these disparate experiences, and that includes Black Americans. And thinking about how systematic racism really perpetuates experiences of different types of stressors. We also know that racial discrimination, as I've said before, does not happen only on the individual level. And we know that things like social economic inequality, residential segregation, even concentrations of poverty and violence are rooted in systematic injustices, which can influence what I just as high allostatic load, so your body not being able to reach this balance, and leading to some of the chronic illnesses that we disproportionately see in Black populations, including coronary heart disease, inflammatory disorders, and even some forms of cognitive impairments. To bring this home, a population that I particularly think is relevant to this discussion, because oftentimes what I see is a discussion of every other type of stressor besides racism, right? So it's really about SES, socioeconomic status, that's really driving health disparities that we see amongst Black populations. But I think maternal health and morbidity among Black women is a key concept to where it really challenges our thoughts around how long-standing, how much has long-standing effects on our health and wellness. One of the things we know in the maternal health literature is that the primary antecedent of infant mortality is low birth weight. Unlike some other health disparities, education and income is not necessarily the primary factor influencing poor trajectories in maternal health. And research has found that babies who are born to college-educated Black women are still more likely to have a lower birth weight than babies born to white women who dropped out of high school. And one of the conceptualizations that is getting more and more research conducted is thinking about how racism fits within this frame. Pregnant women from marginalized communities are at high risk for problematic birth outcomes and maternal mortality, possibly due to historical trauma, exposure to racism and discrimination, and which likely persists for generations. And so I wanted to provide a graphic to describe this process because I think it really takes home some of the concepts that we have been thinking about and other researchers have been thinking about with regard to how longstanding and how intergenerational racism could have effects on the body, the mind, and the body. And so if we think about how racism is at the individual level, community level, and structural level within our systems of care, we can potentially begin to think about across generations and across time how much these historical legacies of oppression are affecting generations of Black Americans across time. And if we don't identify this as such, if we don't recognize these historical injustices that have happened, including slavery, as well as Jim Crow laws, as well as residential segregation and redlining, those concepts that I won't be able to get into today are still very relevant to the outcomes that we see in Black communities today. And it can also be at institutional level and influence the way providers think and engage in presidential behaviors. And that can include things like discriminatory practice in hospital settings, general access to healthcare. And it's important to think about how that plays out over the life course. And so, putting this all together, I think in a time of a COVID pandemic, and I would consider a racism pandemic, I think it's important to consider how these things are all connected and intertwined. There is also a conceptualization that COVID disproportionately affects Black communities because we are experiencing, and Black are experiencing chronic illnesses that are disproportionately happening because of structural racism and oppression. And that is an important consideration to think about within how these things are all connecting to each other. And so the next concept I'm going to talk about is this concept of building a historical consciousness, a concept developed by Angela Davis originally, but why it's important to understand history when we think about mental health treatment and concepts such as racial trauma and how that influences PTSD symptoms. So although low-income Black Americans have high lifetime rates of PTSD and are exposed to relatively more traumatic events, these racial disparities persist even when controlling for trauma exposure and socioeconomic status. And so recent research has been questioning what are some other things that could be influencing these disparate outcomes. And racial discrimination is one of those concepts. And so it's really important to consider the place that traumatic experiences hold in social power structures. So if we think about cases that we have seen, racial discrimination and trauma are not these separate concepts. They potentially are interwoven concepts that we need to consider as impactful in the lives of Black Americans. And I think that's where the root of this concept of racial trauma or race-based trauma has come from. So one factor that people have been thinking about is that may explain these high rates of trauma exposure in African American communities is racial stress and trauma. So this combined effect of different forms of stressors that are affecting the lives of Black Americans. And that is where the racial trauma or race-based trauma conceptualization came from. And Carter and colleagues in 2007 described racial trauma as a dangerous or frightening race-based event, stressors, or discrimination that overwhelms one's coping capacity and impacts quality of life and or causes fear, helplessness, and horror. When I was reading Carter's article, what made me think about this is, why isn't this a part of how we consider PTSD framework? It seems like it's a similar language, but it's not quite considered necessarily the same, or is it? And that was one of the questions I thought about and research in our literature. And what I found when I started looking at how people conceptualize racial trauma and separate it from PTSD or combine it, is that within our DSM diagnostic framework, we have this diagnostic definition of PTSD. And researchers have wrote about racial trauma and how it could potentially fit. But there are also different camps of researchers on this topic, with the thought that the experience of racism is multifaceted. So it's not how we might consider things to be an individual pathology or disorder. This should not be something that we put in a diagnostic manual because it's not something that we want to pathologize. And that makes sense, right? Because racism is happening to the individual, and it's not something that is disordered or something that should be necessarily challenged. It's something that's at multiple levels. But then there's another pocket of discussion of racism needs to be recognized for treatment. And one of the best ways to do that is through a diagnostic manual. Just like how we think about sexual assault, racism could be a type of experience or event that is affecting PTSD exacerbation that needs to be recognized within a diagnostic manual that we all use as mental health providers. And so throughout the literature and research that has been done in this area, people have came and said different statements around what's important to think about as we have this discussion around racial trauma and PTSD. And I wanted to put some of those quotes here. It's important to note that we are not categorizing normal responses to racism as disordered. And similar to rape and domestic violence, racist incidents are the problem and are the root of the disorder. People should not be stigmatized as problematic when they are responding to emotional and sometimes physical assaults to their integrity. And post-racism distress is a normal response to an abnormal experience or a sane response to an insane stressor. And so if you notice from these quotes that I put up, it's the importance of recognizing that maybe we really need to think about racism and how it impacts the lives of Black Americans so that we don't pathologize that experience. And maybe it is something that we either need to consider outside of a DSM framework, or if we do, we have to be really ready to understand this historical consciousness of what it means to not pathologize it, but to understand that it is a chronic stressor. And one thing that we also know about our diagnostic framework is, and our diagnostic manual over time from the DSM, is there is a choice that's made about what can be considered traumatic in our diagnostic manual. And this has changed from DSM versions over time. So we make a choice in our society and as clinicians and researchers of what fits within our DSM framework. And right now we have different concepts that we think fit and things that we do not see. And so researchers have thought about why is it that racism has not been considered in our DSM framework, and potentially that racism can be considered a potentially unique type of stressor and traumatic experience because of its historical legacy in the US and multi-systemic effects. And so when I was doing clinical work, one of the things that has stuck me, particularly when I was doing work with trauma-exposed populations in an urban setting, is quotes like this. And this is one that I heard. Is a person told me, being Black, my traumas don't end. And I think that is something that is important to think about in the lives of Black Americans, is that how chronic these experiences are. And in our PTSD language, even in the wording choice, it's post-traumatic stress, right? So post an event. And racism is something that can be a long-standing experience, and as well as something that is never ending, and it's something that is continuously something to grapple with. So maybe even the language of post-traumatic stress disorder or post-traumatic stress is not potentially the language we want to use with racism when we know that these traumas can be chronic, persistent, and cumulative over time. And so why is it that there are some current researchers asking the question, why is it that racism is not in our DSM? And I think to have this discussion, we really need to think about structural racism on health equity, mental health treatment. And one of those concepts that perpetuates structural racism is a colorblind ideology. And so everybody probably has heard Martin Luther King's speech. And in that speech, he says, I have a dream that my 4 little children will one day live in a nation where they will not be judged by the color of their skin, but by the content of their character. What researchers have realized from this statement, this wonderful statement, is that people have, in many ways, taken that. There's been an uptick in conceptualizations of what Martin Luther King meant by that statement. And some of them have perpetuated what we consider to be a colorblind ideology, and I'll give that definition in a second. But from that statement, we have seen other statements in line with what they think the Martin Luther King statement says of, I don't see color, all lives matter, we're all equal. And that potentially can be something that can be harmful or disruptive in understanding a person's lived experience. So I want to bring up the definition I just pulled, the definition that I had to start with this presentation of structural racism. Again, the societal systems, social forces, institutional, and ideologies that perpetuate racial inequity. Now, researchers have conceptualized that the colorblind ideology goes directly against understanding what structural racism is, and rooted in how people conceptualize Martin Luther King's speech, as well as other political-based discussions, is colorblind ideology is saying only the absence of accounting for race will bring racial equity. So it rejects all racial categorization, record keeping, and makes no distinction based on race. And it relies on the idea that race does no longer matter. If we don't see it, then that means that we are all equal. And when we see things that don't fit in the framework that we are all equal, then that must mean that there's something about that person's individual behavior that is outside of the norm. And that in particular can influence a lot of things that we may not think about, and including what we consider to be structural racist practices, institutional racist practices, as well as on the individual level, those interpersonal levels of racial discrimination. So Dr. Tricia Rose talked about how this colorblind ideology perpetuates structural racism in all of our, pretty much all of our systems of engagement. And that includes the criminal justice system, the education system, the housing system, the wealth and job related system. And one that doesn't get touched on that much is the healthcare system, but that's the one I think particularly is relevant to clinicians and mental health providers. And to bring this home a little bit further, when we have a colorblind ideology, what can happen is if I don't see race, it's difficult to really understand all the components that happen with racism. And so racial discrimination experienced by Black Americans are often not viewed as severe enough to indicate that these individuals may have PTSD. Or sometimes what we've seen happen, their symptoms may be dismissed or trivialized because of the view that stressors are not catastrophic enough, according to the DSM. So what you might see is, particularly amongst non-marginalized communities who providing care, is if you see someone who is coming in with a stressor of racism or racial discrimination experiences, it can be hard if I don't see race to understand I've never had that experience. So it must be something about you that is either disordered or is not quite something that I understand how to treat. And it's not quite something that I think is potentially severe because I don't experience that in my own personal life. And so you can think about how these types of ideologies can perpetuate many types of different types of systems. There is also at the root of this ideology, this idea of incompetency. So Black Americans being viewed as incompetent of their own lived experience and emotional responses in healthcare settings. And a quote from a book that Dr. Tracy McMillan Cotton wrote is, "I have never felt more incompetent than when I was pregnant." And one of the things that we're seeing, the stories, the personal narratives we're seeing from Black women bringing back that maternal health and mortality rate, is the discrimination that they experience in their healthcare setting and medical healthcare setting of just being heard. So not being heard around their pain experiences, not feeling that their voice is confident enough to be something that providers understand or can wrestle with, and leading to some of the health disparities that we see with regard to Black maternal mortality. And one interlocking system that I think also shows, again, how important it is to understand history, as well as how these systems are interlocking with each other. So how mental health fits within our justice system, for example, is here. So 1 in 4 people killed by police in 2015 had a serious mental illness. We know that states with less access to mental health care have more adults in the criminal justice system. And 6 out of the 10 states with the least access to care have the highest rates of incarceration. So Black Americans are incarcerated at more than 5 times the rate of white Americans. And so it begs the question, why is that? And if you start putting the pieces together and you start thinking about these interlocking gears of structural racism, perhaps you can see how all of these systems perpetuate injustice. And as providers, it is a part of our social justice initiative to really wrestle with what that means for us as providers and as social justice advocates. And so the last component that I want to talk about is what do we do? What do we do about it, and how do we conceptualize racial trauma within our current frameworks of PTSD or other forms of mental health treatment? And what I will say is, because I think we've lagged behind in identifying racism as something that could potentially be within our mental health system and practice, there is limited research in this area. So I want to talk about and discuss and just kind of get us to start thinking about what are some of the things we need to consider when we're thinking about promoting health equity and culturally competent as well as historically conscious treatment for racial trauma. First and foremost, I hope that from the previous slides, you could see how racism and trauma are interconnected and multifaceted experiences. And one of the key components is an acknowledgement component of what the lived experience of Black Americans are. And it can't be colorblind, right? So it requires a racial equity lens and historical consciousness. Another quote that I wanted to put up that I think brings this home from one of my patients when I was a graduate student who I was treating for PTSD, stated that some of us did not die like Eric Gardner. We're still here. And I think it's important to note that we may see some particular videos like George Floyd that may make us feel like that's a unique experience for one particular Black American. But one thing we know is that there are a lot of videos that were not made for the lived experience of Black Americans with regard to racism and racial discrimination practices. And those might be the people that are coming into your mental health clinics. And from a researcher perspective, research has been growing in this area of like, how does racial discrimination experiences fit in with PTSD symptoms, if at all? And what we're starting to find is there is a strong relationship, a relatively strong and growing body of literature showing that racial discrimination is related to PTSD symptoms. It has been found to be related to avoidance symptoms, hypervigilance and arousal, negative mood and self-esteem, as well as re-experiencing and intrusive symptoms. We also know that racial discrimination is related to a number of other factors that we know that PTSD is also related to, including depression, sleep difficulties, somatic symptoms and chronic health, concentration problems, irritability, and anger. So if we know these things are related and how these potentially are interconnected experiences for Black Americans, the question is, what do we do about it? I wanted to point out another point that can make it still confusing about what we can do about it, is that if we know racism is multifaceted, it takes a unique lens of understanding what to do. And so in some of our research, some of this research being conducted at the Grady Trauma Project, this is some early data, we really tried to think through the multifaceted nature of racism and try to understand how it can relate to PTSD. So if you see on the screen, there is a concept called cultural racism that's also called vicarious racism. And this is the type of racism where you are witnessing these types of experiences, whether that is on your TV screen or in your social media account. And so you'll see that one of the examples of the items from this questionnaire is you notice that when Black people are killed by the police, the media informs the public of the victim's criminal record or negative information in their background, suggesting they got what they deserved. So one thing we know is it's not just these interpersonal experiences that are affecting hyperarousal symptoms, intrusive symptoms, avoidance and numbing, but it's a broader framework of thinking about all the ways in which racism can be experienced. And cultural racism, particularly at this time, is something I think we should really be thinking through, as well as institutional racism and individual racism. And so if you think about all the mechanisms that can be happening across the life course, so amongst children, amongst adolescents, amongst adults, Black adults, what are these conversations looking like with children who are witnessing these George Floyd or Trayvon Martin experiences over their TV screen and across the media? How does that affect our mental health as well as our physical health? And I think it's important to note that at this time, we don't really know all the answers, but I think we're finding that these components are really relevant and really important to consider in the lives of Black individuals. And if we fail to recognize it, we might be failing the full scope of what people might be presenting with. So in thinking about our current PTSD treatments around racial trauma, if we start to understand that racial trauma just could potentially be exacerbating PTSD symptoms. So if someone has a diagnosis for what we would consider our traditional form of PTSD treatment or PTSD diagnosis, it's important to think about how racial trauma could be exacerbating those symptoms, right? So, and how that might be different than how we might engage in traditional forms of treatment. So for example, some concepts in our evidence-based treatments that we use, such as stuck points or cognitive distortions. One thing I found when I have been treating racial trauma is that it can feel very invalidating to say that experience of racism is distorted, right? So a person could come in and state that that white people are privileged or that white people are racist. That might be something that you might not want to identify necessarily as a cognitive distortion. There are areas I think that are important to consider as things that keep people from moving forward. But I think even our language around stuck points and cognitive distortions might need to be considered and conceptualized potentially differently when we think about racial trauma. And one thing I've found is, particularly amongst Black Americans, we can engage in evidence-based treatments that really root in identifying the lived experiences of Black Americans, validating those experiences, but also trying to figure out a way to engage in value-based living. So it could be a combination of things that we have identified as important things to decrease stress that we can use to really form a treatment. Again, that is why we know that more research is needed in this area, because it hasn't been something that has been pushed in our research literature in the past or pushed forward. And so it's more research is needed to understand what are the most effective treatments for Black Americans across the lifespan that experience racial trauma. If we know that Black children experience distress related to racism and trauma, what will that look like when a Black child or Black family presents into our clinic? It's important to consider how that might look somatically, right? A tummy ache from that stress of racism, and how do we have those conversations? How do they have those conversations in integrated healthcare settings? All of those things I think are important things to consider in our practices. I think it's also to think about how much of a push there has been to engage in trauma-informed care in multiple settings, including school settings, healthcare settings, even some work in criminal justice systems around the importance of trauma-informed care, which allows people to say, instead of asking, why are you this way? We ask, what happened? I think there's a place to also acknowledge racism as an important component to consider for Black people in conceptualizing what's going on, particularly for Black youth, and thinking about why aggressive behaviors might come up, why people might feel depressed or overwhelmed or anxious in this point in time. I think it's a conversation that I think people might stray away from, again, because of some of these frameworks that have been rooted in colorblind ideology frames or ideologies. But I think it's a conversation that we need to have. And so some considerations for interventions that I have been thinking about takes the framework of really trying to identify how all of our systems can be perpetuating or are perpetuating oppression and not identifying racism as a chronic stressor. So if we start to have interventions that can consider the multiple layers of racism that could prevent mental and physical health decline, it might be some conceptualizations that we don't typically use. And so when I think about this, I've thought about this from reading other people's work, such as Cheryl Groves and Helen Neville's, Dr. Helen Neville's work, and considering the holistic nature of the African American experience or the Black American experience. And that the experience of racism, if you think about what you see on a TV screen, as a Black American, that experience of seeing George Floyd killed, that could have been a brother, that could have been a father, that could have been an uncle. And it's a collective experience amongst Black communities of understanding what that means in the context of our US society and the perpetuation of racism that we see. So maybe interventions could include more collective healing processes. And also understanding how healing could potentially come from things like activism and identifying what strengths are within Black communities and Black individuals that we can highlight within our mental health treatments. I also think it's important to note that as psychologists, I think it's important for us to identify ourselves as advocates for social injustices so that we can really disentangle these interlocking gears of structural racism. We know that there is stigma against mental health systems, particularly amongst Black American populations for valid reasons, right? There's historical oppression that has happened in research as well as clinical practice within among Black Americans that can make individuals hesitant to come within another system that can be oppressive. And it's up to us to examine these systems that are perpetuating racial injustices and perpetuating what we would consider colorblind ideology that shows itself in multiple forms. And then think about how we can engage in amplifying the voices of Black Americans and their lived experiences, both in our research as well as our clinical practice. So one way of thinking about this is instead of a Black American coming to my mental health practice or to my hospital, what could it look like if we were engaged in community healing circles that mental health providers facilitated around this collective experience of racism and trauma or racial trauma? And what would be the advantage of that? And so we start to understand Black Americans as not something that is, we're all the same, but it's a unique and important experience that Black Americans face. We can start to consider what are some of the interventions that would be particularly relevant to this population that we may not have thought about before. And so I wanted to touch on this that was published in a Counseling Psychologist recently, that is a push towards trying to identify, again, our research is limited, and I think there is much to learn about what racial trauma interventions are going to look like and what is going to do that. But there are scholars, particularly Black scholars, who are focused on identifying what we can do that might not be something that's considered in traditional formats of PTSD treatments, to make sure that people experience what we consider healing, but also radical healing from the racial trauma that they experience. And you see some of these concepts here. And all of them are kind of rooted in a lens of not a colorblind ideology, but identification of that experience that Black Americans face disproportionately from other racial and ethnic groups. So some final take-home points is that the acknowledgement that racism is a chronic stressful stimuli that is having a significant impact on health in our treatment settings is vital. if we think about and start to consider the things that I've talked about today, about historical oppression, how that has happened and perpetuated over time through our structural systems here in the US, we can begin to say that if we don't address racism, what are we really doing when mental health symptoms aren't going down? Something that I think is of interest to me and my research team is we're focused on conducting focus groups around racial trauma and racism and racial discrimination to really understand how this stressor, based on a person's ability to discuss this with us, how is this affecting your livelihood, your mental health well-being, as well as your physical health well-being? And if we start to have this acknowledgement that is showing itself in all of our systems, then I think we can begin to make some relevant change. Again, if we understand history, then we can consider more racially equitable solutions. So it's important to acknowledge and understand what Black Americans have been through and are currently going through to really understand how to break a cycle of injustice. And once we understand what that means, I think we can be providers that are culturally competent and uniquely and also importantly, thinking of from a critical race concept of what it means for a Black American to be coming into CS in a mental health care setting, and what unique experiences they might be bringing to the table that we need to consider in our practice. And then lastly, I think given our current social political climate, as well as our US legacy, it's important to think about novel ways to engage in communities around therapeutic interventions. If we know that racism has not been considered in our current PTSD framework, and maybe it does or maybe it doesn't, but it's something that we need to wrestle with, if we can think about why certain interventions might not be as amenable to Black populations as we would want them to be. And I think there's further research to really disentangle what are the most efficacious treatments for these experiences. But I think it's important to start considering, and I think we're on the right track, as I've seen many scholars, particularly Black scholars, focus on research. So I'm hopeful for the future. And so that's it. I want to thank you so much for your time. My contact information is here if you have any questions that I can answer or facilitate. So thank you so much for your time.
Thank you so much, Dr. Carter.
No problem.
If you are not yet an ADAA member, we invite you to view the many membership benefits that ADAA has to offer. ADAA members enjoy year-long access to continuing education programs, free access to special interest groups, including online peer consultation groups, promotion of your practice in ADAA's online Find a Therapist database, and significant discounts to ADAA's annual conference. We would also like to invite you to check out more ADAA on-demand webinars by visiting adaa.org. On behalf of ADAA and our presenter, we thank you very much for joining us today.